Now that leads us to the next and the final topic, which is unfortunately the most serious. What happens when the cancer jumps ship and goes metastatic? And I'm going to ask Dr. Garget to tell us, well, how often, where does it tend to go to, and how do you know it's happening?
So yes, so most of the patients who have muscle invasive bladder cancer, they get through chemo, they go through surgery. After that, we do a very close monitoring of these patients. We do obtain scans every 3 months initially to watch very closely, because if there is a risk of recurrence, the risk is highest in the first 2 years, but and then gradually the risk goes down, and we keep monitoring them anywhere between 5 to 10 years depending upon what we are looking for. And so those scans cover the whole body. They look at the chest, they look at the abdomen, they look at the pelvis, so we make sure we look for any evidence for cancer in the lungs, liver, bone, or lymph nodes. And having said that, our main goal of these scans is to catch the cancer very early. Even if it is showing up, maybe we want to catch it very early in the phase so that we can do more aggressive therapy upfront. And and when we do this kind of surveillance scans to look for the evidence of cancer coming back after surgery, most of the patients don't have symptoms. We want to catch them before even it causes symptoms. So so most of the patients get to know that if there is evidence of cancer coming back based on the scans. Very rarely if it is an aggressive scenario where the cancer did not respond well to initial chemotherapy, or there was more evidence of cancer at the time of surgery, sometimes patients have symptomatic recurrence in the form of pain or a discomfort based on the location of the cancer.
Right. And uh, Yosef, what can we offer these patients? Is the same stuff as before if the cancer is metastatic, and what if they've had all the right things already, like the chemotherapy, immunotherapy? Are there other new drugs or treatments that are available to people now?
Sure, yes. Depending on the timing of chemotherapy, if they recurred, if the tumor recurred like 1 year from the initial chemotherapy, you might consider rechallenging with chemotherapy. So give them the chemo again. Immunotherapy, as we discussed, we have 5 different immunotherapy agents which target the same pathway. We call them PD-1 and PD-L1 that are FDA approved. However, the response rate with those agents are only about 20%, meaning if you treat 10 patients, 2 of them will have a response. So here at the university and many other academic places, we are trying to improve those numbers by offering what we call clinical trials, by combining, adding other agents on top of immunotherapy to boost that effect of immunotherapy. That's the way how we advance science and how we move forward with or come up with the new treatment options. There are other options beyond immunotherapy, like we have a drug called Padcev or enfortumab vedotin. It's like an antibody to a certain receptor that is overexpressed in bladder cancer. Has shown nice results, close to 50% response rate. We have oral pills for a specific bladder cancer population called who have a mutation called or genetic alteration called FGFR mutation. Now we use oral pill for that. Just last week, actually, the FDA offered a fast track approval for another drug called sacituzumab, another antibody that have shown benefit in bladder cancer. So the field is moving fast. However, here at the university, we always prefer to treat our patients on clinical trial. And I cannot stress enough on that because A, it gives you extra line of treatment options. And B, more importantly, that's how we advance the science and come up with the new treatment options.
And Rohan, haven't you, in fact, been the lead investigator for your own institutional trial, the Abatex trial? Can you tell us a little bit about that?
Yes. So as Dr. Zakaria mentioned, immunotherapy, there are a lot of new drugs, but they work in about 20% of patients. So definitely there is a very big room for improvement. And one of such approaches, clinical trials. So we actually at University of Iowa have our own clinical trial where we are looking at different mechanisms to improve the outcomes with immunotherapy. if immunotherapy alone is not doing the job, can we combine it with chemotherapy? And based on that concept, we actually have an ongoing clinical trial where we have combined chemotherapy with immunotherapy and have definitely almost doubled the response rates. On an average, if we expect about 18 to 20% response rate, we had this ongoing trial with 21 patients, and we have seen a response rate of almost 50 to 60%. So number of patients achieving a better response with shrinkage of tumor, and that too for a longer duration, we have seen a better response. So these clinical trials are actually promising because they are not FDA approved yet. They are trying to look at combining novel agents, making current therapy work better. So there is not much placebo kind of therapy involved. And these are early phase 1 studies. For these kind of studies to eventually get FDA approved and to be available all through, through any other insurance mechanism will take years. And we at university give the patients an opportunity to get more advanced treatment, more science-based, more rational options, so they have better outcomes.
Exactly.
And actually, just to add a point to that, in general, the research has shown that patients who participate in clinical trials have more better therapy and more better outcome overall compared to the ones who don't go through clinical trials.
Right, exactly. Now, we talked about a strong role for medical oncology in metastatic disease. How about the role of radiation and or surgery once the disease has become metastatic? Are there some cases where it does help? Let's start with Mark.
Yes. So radiation provides excellent local control and palliation of symptoms. So a great example, I think, of the use of radiation in this setting would be if there's a bone lesion that's causing pain. We can give radiation to that bone and help relieve symptoms there. Another common application is what we call SBRT, or stereotactic body radiotherapy, where if there's a spot, for instance, in the lung, we can give very focused and pinpoint radiation on that spot in the lung. And it's really just amazing technology that's been developed over the last 5-10 years, so much better than what things were beyond 10 years ago. And just amazing technology. And we can do things with radiation to help with symptoms if the cancer does become metastatic.
Thank you, Mark. And Vig, how about, is there a role for just going out and cutting out more? Or are there special circumstances where you have an area you can go after? Dr. Pakian, you're muted right now.
Here we go. So we generally don't think of surgery as being able to cure disease once it's spread outside of the bladder. But there are some situations where we can cure patients where it has only spread to the lymph nodes if we are able to completely remove everything. People have tried to do bladder removal surgery when cancer has spread to distant organs. And we've had the most success with this if it's more limited spread, so 1 or 2 metastatic sites. And some organs work better than others, most notably the lung. So if there's only 1 or 2 spots in the lung, sometimes we are able to cure patients by removing the bladder and those lung lesions.
Great, thank you. And sometimes, despite everything, the cancer runs its course. Jane, if you're still on the line, can you tell people about the hospice program, when it's appropriate, and what sort of resources that provide?
Sure. And I also include palliative care in this. At the University of Iowa, we actually have a really great palliative care program. And often Dr. Zachary and Dr. Garget will have palliative care involved with their patients who are maybe even still getting chemotherapy, but they do have metastatic disease and they need some assistance with managing some of those symptoms related to the spread of the disease. Some patients may have more pain, some patients may have more trouble breathing, depending on where the cancer is spread through. And our palliative care team, they can help manage those symptoms in somewhat of a better way and help the patient be more comfortable, even while they continue getting treatment. So that's one service. So the palliative care is more in combination of you're still getting treatment, but we're going to manage your symptoms a little better, make you more comfortable. And then hospice care is something our social workers work with very closely with setting up patients at home for care. And this may be closer to, we're going to finish treatment now. We're not going to take any more treatment. We just want to spend our time with our family, with our friends, but we want to be comfortable at home, and we still may want to get around at home and do some things we still want to do. So then we'll call in the local hospice team, and it might be through the local county. It might be through somebody's local hospital. They have hospice teams. And our social worker will contact those teams and set them up with the patient. And the patient at the start will kind of decide on how often they need that visit from the hospice team. Maybe they just come out once a week, see if they're managing their pain medicine okay, or their nausea medicine, if there's any other assistance they need from them. They often think of hospice as, oh, you can't do that until you only have 6 months left to live. Well, you can ask all of our doctors on the panel if they are really fortune tellers and can really tell exactly if a patient has 6 months or 2 months or 3 months. There's always estimates, but the social workers will say often there's not really the wrong time to start hospice care at home if the patient's ready for that. But sometimes all of a sudden, maybe the patient will get to feeling better and they may discharge them from hospice for a little while and then go back to hospice later again. But that is a service that most counties will have in one form or another. And payment is often related to Medicare or other insurance. And the social workers all have ways to work that out for the patient to help with the payment of hospice. But normally the patient does not receive hospice bills.
Excellent. Well, thank you. Well, this concludes our formal program about those 3 types of bladder cancer patients and what both in general and what kind of services that we can offer on all different fronts from the beginning to the end, as you just heard. I'm going to just thank BCAN for organizing this program, and for Amanda Ryman, who is our marketing department at the University of Iowa, who has contacted all of you and made this one of the biggest programs we've ever done. And I hope this will be a lead-in to helping to create a University of Iowa bladder cancer community. It's going to happen if you, the patients, the participants, can organize together with BCAN. They've started communities all over the country, and Iowa, despite having 6,000 patients living with bladder cancer, we've not yet taken that next step. And I hope this will be a prompt and a call to action to organize us together. The other thing I want to tell you is that both BCAN on a national level and the University of Iowa on its foundation level happily are trying to raise research dollars for bladder cancer and advocate on your representative level and on the congressional level to try to get more funding. Bladder cancer is the 6th most common cancer overall. It's the 4th most common cancer in men, and it is like the 25th most funded cancer there is. And so we are well behind everybody else. It's as if nobody knows about us and nobody cares. So your voice makes a big difference in all of that as well. I'm going to turn you back over to Morgan, who is going to help conclude this program and tell you how to give us additional feedback and how to contact us in the future. So thank you all for participating. It's been a great experience for all of us on the panel as well. So Morgan.
Thank you, Dr. O'Donnell, and thank you to our esteemed panelists. Your expertise has been amazing this evening. Before I conclude, I had one very quick question submitted in the middle of the program, and that was, how often does a quote unquote mid-grade bladder cancer end up going for bladder removal surgery? So think those T1 high grades, T2s.
So the mid-grade would be, or the mid-risk would be the low-grade multifocal, still TA, but the T1 high grade is the high-risk non-muscle invasive, and I think that's the question that may be directed. Is that where I'm understanding it?
I believe so.
It's about 20% will actually progress to stage 2 or muscle invasion, as Dr. Packiam mentioned. In addition, we think about 15 or 20% will fail the therapy so many times that despite the fact that it hasn't progressed, it's reached a point where we can't control it. either the cancer keeps coming back so frequently, it's just a matter of time, and we preemptively strike to remove the bladder or do a more advanced systemic therapy, or it has created what's called a bladder cripple. That is, we might get the cancer almost all gone or all gone, and then the bladder is shrunk down and people are miserable, and they know their bladder is no longer their friend, and it's time for it to come out then too. So those are two scenarios that sometimes play out.
Great, thank you so much.